Alright. Hello and welcome to the Spine and Nerve YouTube channel. Dr. Joves, Dr. Nicolas Karvelas. Today, Dr. Karvelas, what are we going to be talking about?
So today we're going to be addressing a very common presentation not only to an interventional pain clinic but just to medical clinics in general. So specifically knee pain and more specifically knee osteoarthritis.
Yeah, so knee arthritis is one of those things that, for all of us, if we live long enough, we're likely to experience, some elements of knee arthritis over time. And very commonly, I think we see this coming into our clinics, not always just from, athletes and not just from very old patients, elderly patients, but also coming just, normal weekend warriors and people that are trying to live their lives and trying to be functional and active. And so can you give us a little bit of the history of knee arthritis?
Yeah, definitely. And that's one of the things we want to do with each one of these, pathologies, each one of these disease processes is go over the common clinical presentations. So as always, being systematic, thinking through the location, the quality, the radiation, severity of the symptoms, timing, what makes it better and worse, and the important associated symptoms. So starting with simple localization. So patients obviously are going to be describing fairly localized knee pain depending upon which compartment of the knee is involved. So as we know, we have three compartments of the knee: the medial, lateral, and then the patellofemoral or more anterior compartment of the knee. So depending on which compartment of the knee is involved, then obviously the pain is going to predominantly localize to that region. In general, and depending upon the patient, depending upon certain biomechanics, but in general, medial knee pain is one of the more common presentations of knee osteoarthritis. So after we've talked about localization, then we start to think about the quality of that pain. So very common, I think, for patients when they're describing their pain due to knee OA, that they have a achy pain that can be sharp with exacerbation. I think in arthritis in general, that's a fairly common description from patients, kind of a baseline ache with a sharp pain with exacerbation. Radiation, so although there can be some level of referred pain with knee osteoarthritis, for the most part, it's a largely localized pain to the knee. If there is some radiation of symptoms, like I said, that's not impossible in knee osteoarthritis, but you do want to make sure that you start to think about other disease processes if there is a significant radiating or radicular component to the symptoms. In terms of the severity, of course this is going to be variable from patient to patient, but like we've talked about in other talks, it's always critical to assess the severity, because the severity of the patient's symptoms and specifically how those symptoms are impacting their function, quality of life, what they need to do, what they love to do, that's going to drastically change how we approach, how aggressive we are and how we approach the management of that patient.
And in terms of the severity, I think this is one of the things that we often see with arthritis, is that it does tend to be this kind of progressive thing, right? This kind of, it starts, it's there, it's kind of achy, kind of bothersome, comes and goes, and then eventually becomes a little bit more consistent, bothers them a little bit more over time, and then that severity grows. Did you say that's correct?
Yes, absolutely, yeah. Now in terms of the timing of these symptoms, so like Dr. Joves just brought up, it's very common with osteoarthritis that there is some level of a gradual progression of arthritis. There may be, I would say it's also not uncommon that there may be an acute exacerbation that brought that patient to the clinic, even though it's been, kind of there and nagging and growing over time, but then maybe they had a fall, or maybe they went on a hike, or something that flared that arthritis pain up to the point where they actually present to the clinic. The other important thing with timing in terms of knee osteoarthritis is that it's not uncommon that this type of pain can be worse after periods of immobility, including first thing in the morning. Overnight that joint's not moving, is not producing as much synovial fluid, and then when you try to move, there can be some stiffness and pain associated with that, which can then improve with gradual movement and trying to loosen up that joint. If we're thinking about degenerative osteoarthritis versus inflammatory arthritis, obviously with the degenerative osteoarthritis, that improvement's going to be typically in less than 30 minutes for that patient. Now in terms of the accentuating and alleviating factors for the knee osteoarthritis, so of course any weight-bearing activity on that joint is going to exacerbate symptoms. So walking standing for prolonged periods of time, that's going to worsen, bring to the forefront that patient's knee osteoarthritis pain, and then of course rest is going to be something that potentially can alleviate the symptoms. In terms of associated symptoms, so although there can be some level of swelling with knee osteoarthritis, we generally don't see severe swelling of the knee joint with degenerative osteoarthritis. So I say that because if you do see significant swelling, advanced swelling of the knee joint, then you do want to make sure that you're thinking about potentially advanced diagnostic workup, including an MRI or other diagnostic measures to determine, okay, what else potentially is going on here. And then again, in terms of associated symptoms with a joint, you're always making sure that you're not having, concerning significant warmth or redness of the joint, which again would raise concern for a separate process than the baseline degenerative knee osteoarthritis. The other thing I would bring up is that in terms of neurologic deficits, so obviously with a knee osteoarthritis picture, we're generally not going to see, too much neurologic changes. So if you have knee pain with some associated numbness or significant weakness, although not uncommon to have pain-limited weakness or deconditioning and general weakness of that limb because of avoiding use of that limb. But if there's focal weakness, focal numbness, then again we might start to think about other things that can cause knee pain, but may have more of a nerve component to it, such as a radiculopathy. Obviously, for example, an L3 radiculopathy can cause knee pain, but then have that weakness and numbness associated with it.
All right, so we have a patient coming in, progressive pain over time, got better, got worse, and then now it's starting to interfere with their life, right? And so they came in, you asked about all of the red flag things, they're not getting any significant redness or swelling, no fevers or chills or anything along those lines, nothing like numbness or weakness. How do we start thinking about this patient, and how do we start kind of talking them through those next steps? They're presenting, they're ready for something to change, so kind of take us from there.
Yeah, and so again, it's always important to be systematic here. So like Dr. Joves always does a good job of, bringing up his algorithm approach, and I have a very similar one as well. So the things I think about in terms of treatment of really most musculoskeletal or spine disease processes, but definitely knee osteoarthritis as well, is lifestyle modifications, activity modifications, therapies including physical therapy, obviously medical equipment, and then medications, starting with topical medications first in my mind, procedures, and then more of the advanced, minimally invasive surgery, even surgical intervention, and then any additional diagnostic workup that I think might be important. So that's the typical systematic approach I take. So starting with lifestyle modifications, so we know that, and there's multiple studies demonstrating this, that weight optimization is critical for knee osteoarthritis. You'll see statistics out there, a little bit of a range, but in general, for every pound that you're able to optimize or to lose, that's the equivalent of taking 4 pounds off the joint. Like I said, you'll see some variability in the literature there, but in general, there's this significant improvement in the stress on the knee with weight loss.
And that's the point that I always like to take a little extra time to talk to patients about, because I think it's something that's really underutilized and underthought about from the patient perspective, right? I mean, when we're thinking about joints, there is a physics equation across each joint, right? And so, there's an amount of stress and the amount of stress that's able to be withstood by the joint. And so, if you talk about something even as little as 5 pounds, right? Which, I think for the general American public, 5 pounds is a very reasonable, doable thing in a matter of a couple of months in terms of, optimizing nutrition and diet and exercise. And 5 pounds equals 20 pounds of force across that knee with every step. You figure if the average American walks, I don't know, I'm going to make up a stat here, somewhere between 2 and 10,000 steps a day, 20 pounds per step, it's a lot of decreased force across that knee. And so as much as obviously we do end up focusing on all of the next things that we're going to talk about, I feel like this is one that, making sure that patients understand really well up front helps, because it is something that gets lost fairly easily.
Yeah, and I think one thing that I've found over the years as well is that using the term weight optimization can be really helpful for patients. I just notice, just in terms of patient provider interactions, when you start to say the terms lose weight or weight loss, of course that's what we're talking about, but weight optimization, I feel like, number one, that gets the message across, and also I think it hits patients a little easier, and continues a positive interaction.
I much prefer weight optimization than weight loss myself.
So,
point of reference to me.
So those are, and then of course, like Dr. Joves brought up, diet is another critical thing, and there's a lot of information, growing information about anti-inflammatory diets, which can have a positive impact on a lot of different chronic pain conditions, and we could spend hours and days talking about that, but there are some good references out there, I think, to start patients out with, if you don't already have that in your clinic, in terms of something you can give the patients to reference. But I think Dr. Andrew Weil is a good reference. He has a good website that patients can look through and see, okay, what are foods that potentially can decrease inflammation and improve pain. So yeah, diet, weight optimization, those are critical. Now, moving to activity modifications, this is going to depend upon the severity of the patient's symptoms and whether you feel like there needs to be a period of relative rest followed by a gradual increase in the level of activity. But for the most part with osteoarthritis, we're not dealing with a fracture or another acute severe injury, so we generally don't have to be as strict or as rigorous with our activity modifications there. Although, like I said, it is important to give the patient guidance on how they're approaching. We definitely don't want them suddenly increasing their level of activity, trying to get that weight optimization. We want to be careful and graded with all of our approaches. From a therapy standpoint, so as we all know, there's a lot of good evidence in terms of strengthening of the musculature around the knee, like most joints in our body, and same thing goes when we talk about the spine. For any structure, whether it's a building or a joint or your spine, the stronger the support around that structure, the less pressure on the individual elements. And that's what I generally emphasize to patients. So we really want to work on strengthening the musculature and the structures around that joint, obviously including the quads, quadricep musculature, because that will ultimately decrease that stress on the joint itself. From an equipment standpoint, so things you can think about obviously are knee braces, including unloading knee braces. So this is where you look at the image, listen to the patient's symptoms, because depending on which compartment you want to unload, that's going to depend on what their x-ray shows and where their symptoms are localized to. So it's important to take that into consideration. Heel wedges also can play some role, and there's some level of evidence for that. So that's something you can think about as well in terms of, again, decreasing the amount of stress through a certain specific compartment. From a medication standpoint, so going through our algorithm from a medication standpoint, like I said, I want to first think about topical medications if possible, especially because when we think about knee osteoarthritis, like Dr. Joves brought up in the beginning, it's not uncommon that we're dealing with an elderly population, and they may have comorbidities. They may have atrial fibrillation on anticoagulation. They may have other, coronary artery disease with a stent and on antiplatelets. So we want to be very cautious in those settings with some of the more typical oral medications that we may use, including obviously Tylenol, and then but specifically in terms of those examples I brought up, oral non-steroidal anti-inflammatory medications. So the reason I say all that is because a topical anti-inflammatory medication, something along the lines of diclofenac, can be very helpful in those settings, both to improve symptoms while minimizing risk to the patient.
Yeah, I think that's one of the things that you're going to consistently hear from us, is that we really believe in topical medications. I think this is a perfect example where there is a opportunity for medications to interact with each other. You have risks that are associated with taking oral medications and topical medications. Diclofenac. Some patients even do well with thinking of different combination creams that include some forms of lidocaine and menthol and salicylate. And so there are different topical formulations that are available, and for a lot of our patients we do see that they do quite well with these. I want to cut us off right there. We're going to stave the interventional and some of the surgical topics for next time, but that is our intro and kind of the early steps of knee arthritis.
Thank you, guys.
All right.